October 25th. But it's a particular pleasure for me because I get to introduce a friend of mine from that goes way, way back. And so Rushika Fernandopulle is a practicing physician at Harvard Medical School and at the Mass General Hospital. He earned his initial bachelor's degree as MD and his master's in public policy from Harvard, and then completed a brief foray of clinical training in surgery at the University of Pennsylvania, and then saw the light and returned to internal medicine and completed his residency at MGH. Currently, he is the Chief Innovation Officer of One Medical, a leading advanced primary care company based in San Francisco, California. However, he is known as a game changer in healthcare. He's also been described as a disruptor of disruptors. And that reputation started before his current position when he was the co-founder and CEO of Iora Health. He also was the first executive director of the Harvard Interfaculty Program for Health Systems Improvement and the managing director of the Clinical Initiatives Center at the Advisory Board Company. He's a member of the Albert Schweitzer, Ashoka, Aspen, and Salzburg Global Fellowships and has authored or edited many publications. You know, last year we did one grand round where we did it in an interview format and we got all kinds of good feedback. And so I thought it would be fun for me to interview Dr. Fernandopulle, Rushika, about sort of his being a disruptor of disruptors, about trying to build a better healthcare system with values that I think will feel true to all of us. And so with that stage, I'm going to start out and ask Dr. Fernandopulle to walk us sort of through his story and then to really think about, ask him about where he thinks healthcare is going in the future. So Rushika, it is great to have you here. Thank you so much.
You are welcome. I'm sorry I'm not in person in Atlanta. I'm in one of our practices in Hanover, New Hampshire at the moment, so a little further north.
Well, you know, I knew you as a relatively young physician, younger than you are now. And even at that very early stage, you were really troubled by what you saw in our healthcare system and how it served people. I know that eventually evolved to a realization that you believed that we didn't need to just tweak systems, but instead had to tear down systems and reconstruct systems. So can you tell us about that journey, what you saw as the problem and what your pathway was until you actually started to build Iora Health?
Yeah, so I like probably most people on on here, I went into medicine because I thought I was going to help people, and I think realized that the system we had, they're largely good people and very good intentions, but the system wouldn't allow us to do it. I remember actually one day, a moment, I was on one of the faculty practices at Mass General. It was a February day in Boston where it's cold and dark, and I had 30 patients booked, and they all showed up, didn't have time to go to the bathroom, let alone have lunch. And
none of our people can relate to that.
Yeah, but. And I just they just put its new electronic health record in, and I wasn't very good at it, so I couldn't fill out all the points and clicks during the day. So what I had to do is run around with a scratch pad of paper and jot notes down, and then at the end of the day, stay for about 2 hours. Again, missing dinner with my family to try and finish my notes so I wouldn't get yelled at. And I had a colleague sitting next to me doing the same thing. So it wasn't just me, the system was poor. And she said something very profound. She said, Rushika, every day I lose a little piece of my soul. Every day I lose a little piece of my soul. That these patients come to me and they have such big needs. And when we've got all this training and resources to help them, but the system doesn't allow me to do so. And then the really damning thing was, and it seems to be getting worse and not better. And that was, I think, the realization that, maybe we need to fix the system and not just put up with it. And I think the second insight was that maybe, I did spend a lot of time, it's not a secret the system doesn't work. But what everyone else was doing at the time was what I call incremental change, is try to tweak it. And I said, maybe there's something rotten to the core. Maybe what we need to do is sort of blow it up and start over. And the key there is really about that what we had done is built a system which is very transactional, about document code, bill next, right? And it's throughput, RVUs, all the various pieces to that. And it's 99214, not a 99213, and how many checkboxes you do. And last I checked, the point of healthcare, the reason I went into it, the reason patients come to us is because we're trying to heal them. And last I checked, that transactions don't heal people, relationships do. So maybe what you do is get rid of the transactions and rebuild the system on relationships. And I think, one of my favorite quotes is from Michelangelo, the great sculptor, and someone asked him, how do you get the Pieta, this beautiful sculpture that is in Florence? He said, it's really simple. I take a block of stone and I chip away everything that's not the Pieta. Right. And that's what we need to do. Like medicine for tens of thousands of years, it's a beautiful thing. And we've added all this cruft onto it, and I think instead of just adding more stuff, which is what most people do, we have to take it away and start over. So that was the inside. Many people think these thoughts. I had the great fortune of running this interfaculty health policy program at Harvard, where a bunch of my time was protected. And so I was able to sort of do some thinking and go around the country and meet people and say, like, if I was going to start over and build a model for healthcare. And by the way, this is to change all of healthcare. We'd start with primary care, because we're going to start, instead of top down with the hospital, bottom up from the consumer or the patient, and rebuild primary care and use that as a lever potentially to change all the rest. And what would it look like if we started over? And the goal was simply to make people healthier and not do more stuff to people, et cetera. And one of the people I met was one of the Disney Imagineers, and they taught me about backloading constraints, don't front load them. So imagine you can do anything, and later sort of puts the constraints on the back end, and really came up with some great ideas of what we were going to do. And I went around to all the big health systems in town in Boston, the Mass General, the Brigham, the BI, Mount Auburn. And I said, look, I've been working on this project through this Harvard program. What if we built a new model of care from the ground up? Will you let me have just one practice where I can try this stuff out, right? I have lots of good ideas. Half of them are probably wrong. I won't know until I build it. And they sort of all pat me on the head, and they said some version of, that's really interesting, but our practices are full. We're making money. What's the problem you're trying to solve? And I was like, care sucks. Patients hate it. Doctors hate it. It's bankrupting the country. But unfortunately for them, those weren't their problems. So I decided, in a sort of fit of craziness or bravery or whatever the adjective you want to use, is I'm a doctor, I can start a practice. So I'm going to do it. So started a little practice in a place called Arlington, Massachusetts, just outside of Cambridge, called Renaissance Health, Rebirth of Primary Care. By the way, bad idea, because I can't spell Renaissance and no one else can, but seemed like a good idea at the time. And so we really started it. That's what it started out with, one little practice. And can we actually try to build a new model of care? That worked for a while. We learned a ton by doing that, and we can talk more about the model, et cetera. But eventually, the powers that be around Boston got upset at us. We were accused of raising expectations, that we were making other practices look bad. And do you understand this could upset the status quo? Which the answer, of course, that's what we're trying to do, you idiots. But we ended up pivoting and saying, like, what we should be doing is serving sort of employers and other people. So we started doing this, with the Boeing company in Seattle and casino workers in Atlantic City. And that really set us off on the journey to really change the model.
So your ideas are starting to pick up steam finally. You still actually, I think, need a whole bucket of cash to try and make this a go. But I think you did start to get some investments for a new care model, and I'd be interested in that. But I think I think that you knew there were a lot of components that you believed were important for this care model. That included how you care for people, the electronic health record, the business model. So kind of let's take those apart a little bit. And so tell us a little bit about, first off, how you cared for patients, what the care model was for the patients, and how that started and how it evolved.
Yeah, so the key, again, one of the key insights was the goal was try to not do more stuff to people, but actually improve their health, and that we're going to base this on relationships and not transactions, right? So what the first insight was that the job to be done for the practice was actually different. Remember the old practice, you think your job to be done, to quote Clay Christensen, one of my mentors, you walk in the door in the morning and you have 20 odd patients, 30 patients booked. Your job is to see one and as quick as you can, bill as high as you can, turn your brain off and go to the next one. I said, that's the wrong job to be done. The job that I want to do is that I have a population of people, I know exactly who they are, and my job is to improve their health and keep them out of trouble and do whatever it takes. Right. So if you think that's your job, you start really changing what you do. The first is you realize that as a doc, Of course, we're important. We think that. But what we do is we tell people our job is to diagnose and prescribe. That's not the hard part, right? So people would come to me in my 7 minutes and I'd say, you, Wendy, should eat less, exercise more, take your medicines. Good luck, sucker. I'll see you in 3 months. And in 3 months, you came back and you didn't do it. You bad, non-compliant patient. What did I tell you? Eat less, exercise more, take your medicines. Good luck, sucker. Do it or you will die. Good luck, sucker. I'll see you in 3 months, right? Of course, that's not. That what we need is a team to really engage with patients, to really create it's all about behavior change, right? And so what we evolved is a really big team model, 3 or 4 people per doc. The core of these people we call health coaches. And they're folks from the community, speak the language of the people they serve. Their job is to really work one-on-one with patients to actually execute on the plan that the docs come up with. But I don't love the word health coach. I have bad memories of a high school wrestling coach. Drop and give me 20. The best word is that, again, one of my mentors, Paul Farmer, used when he did this in Haiti. He called them accompagnateurs, one who accompanies you in the journey to health. Now, I can't spell accompagnateur. That's why we don't do that either. But they're really important. We have 2 or 3 of them per doctor. We also have behavioral health specialists because there's so much depression and anxiety. Social workers to try and Maslow's hierarchy and deal with what people now call social determinants. I don't like that word either, but it's just poverty, and really sort of build a team around people. And we start each day in our practice with a huddle where we sit around the table for 45 minutes and we talk about our patients. And not necessarily the people coming in today. We'll figure that out. But what about the people who are not coming in, who we need to do something to? We obviously see people in what I call omni-channel care delivery. So of course we see them in person, but we also can email them and text them and video chat with them. We're proactive and not just reactive. Remember, if we're on the hook for a population, the stupidest thing to do is sit in your office and wait for people to come in. What you should be worried about is the people who are not coming in. We're sitting on the couch eating their Doritos, sort of not doing the right thing. We need to know who they are and reach out to them. Now, we've done a lot of stuff with groups, with patients coming together. We don't call them groups, by the way, or classes. We call them clubs. Everyone wants to be in a club. Diabetes clubs and hypertension clubs and Zumba clubs and aging clubs. We sort of build a de facto narrow network beyond us. The real thing is do what it takes. So we do things. Our health coaches take people grocery shopping. They'll go around the aisles with them and say, let's pick up everything you'd rather get. Now let's look in your cart. Why is this particular thing a really bad idea? Because you're diabetic. Let's put it away and get something else in your grocery store that's better. Take it home. Let me know what it does. We have hundreds of these really great stories. So one of my favorites, we had a patient in one of our practices in Atlantic City, New Jersey, and he was a heavy porter. He had diabetes, hypertension, hadn't taken care of it, ended up on dialysis. So he would go 3 times a week to the dialysis center. Mr. Edwin was his name. But unfortunately, poor Mr. Edwin also had an anxiety disorder. So every now and then he'd be plugged into his dialysis chair and it was beeping and he'd be, I got to move, got to get up. They'd unplug him because he's competent. He'd go home. And guess what happens? The next day he shows up in an ER in renal failure. He's got RALs up to here, and he's got a K of 6, and he gets dialyzed, inpatient dialysis for 2 days, gets sent back home. They gave him an Ativan tablet. He hates it, so he throws it out on the way out. And this pattern repeated. 13 admissions in the last 6 months. $250,000 of healthcare costs. And so our health coach, who's pick for empathy, remember, like, Mr. Edwin, that must be awful. Oh, yeah, it's awful. And that's a great question. Hey, Mr. Edwin, are there times when you're not in dialysis where you feel you have to get up and move? Oh, it happens all the time. Is there anything you do at home that makes it better? Or at home, I put my music on and it calms me down. So, she comes out to me and we give our health coach this little budget. Can we buy him one of these iPod thingies? I was like, absolutely. So we go on eBay, $35 used iPod shuffle. And we, I said, what music does he like? He likes merengue. We'll get the girls to bring their merengue CDs in, block an hour out and download those things onto, this is a pre-Spotify days. You had to download onto the iPod, downloaded the iPod, and the next week he comes in. I told him to stop what we were doing. We go into his room. Mr. Edwin, congratulations. You win the Patient of the Month award, which we, of course, didn't have. But I want an excuse to give him this. Here's your prize. Oh, my gosh. Put it in. Oh, it's my favorite song. Great. Every time you go to dialysis, I want you to take this, listen to it, and think of us. Next 6 months, 0 admissions. right? It actually worked. But $35 used iPod Shuffle saves $250,000 of healthcare costs. By the way, why does no one do it? Because they think their job is see one patient time, do what you can bill for, as opposed to I have a population of people, they're my problem, et cetera. So it's not a little different. It's really a very different care model.
About 12 questions I could ask you as a result of that. Just briefly, you though, just to touch on part of the model, you mentioned that the coaches, wrong word, but the coaches are trained for or like selected for empathy. And then do you train them like in the community? So is there a training program for the sort of healthcare?
Yeah. You know, absolutely. So hire for empathy, train for skill, right? I can teach anyone anything. I can't teach empathy. And so it's a 4-week upfront training program and about a 6-month sort of on the job training. They're really good after about 6 months. And, you know, you teach anyone how to do motivational interviewing, how to do EKGs, how to, you know, they also serve as an MA because it gives them an excuse to lay on hands. It sort of changes a relationship. But yeah, no, so we've hired, and by the way, these are great jobs. These are actually really good jobs in the community. And a lot of our best health coaches came from working at Dunkin' Donuts and Sears and Target and Starbucks and, you know, other service jobs. And they now have a healthcare and they give them a career track. And many of them end up becoming nurses if you have actually gone to medical school, which is great.
No, it's fantastic. So, so the other two components you talked about, I know, are the electronic health record, but also then the business model of how this works. I think probably most of our listeners right now are like, well, that sounds great, but how do you pay for this? So can we go to the business model next?
Sure. So, right, that's the elephant in the room, right? So why does most people not do this? Well, you obviously, most of the things I just talked about, health coaches, huddles, group visits, you know, all buying iPods, you know, last I checked, there's no CPT code for buy iPod on eBay, and there's no CPT code for spend an hour downloading Merengue onto said iPod. So that's why people don't do it. So we realized we had to get out of the fee-for-service model. Remember, fee-for-service encourages transactional things. We wanted a relationship-based payment model. So first thing was let's actually build a relationship-based payment model. Having a fixed amount for primary care. And really, we started doing this retail by simply asking our patients, look, your insurance seems too stupid. We're going to build a new model of care. Your insurance is too stupid to pay for it. If everyone paid us about $40 a month, we'll get on with it. And if you're poor, pay us less. If you're rich, pay us more. And that's what we did. We eventually started getting the self-insured employers to start paying for this. So we went to people like the Boeing Company, mentioned the Casino Workers Union in Atlantic City and said, why don't you pay us a fixed amount for this? So it really is, and then the other piece, by the way, is that we're doubling down on primary care. So primary care and prevention in the US is about 5% of total healthcare spend. It's ridiculous, right? I mean, it's 95% what we spend on is failure of primary care. So what if we double down or triple down on it, that we spend 10 or 15% upfront? What we'll do is we'll save it on the back end, keep people out of the hospital and the ER. I still attend at Mass General. I play a little game with myself. I go around the ER every now and then. What percentage of the people sitting here could not be here if they actually had great upfront care? Walk around the medical wards. What percent of people would not be in these beds? The answer, by the way, is 40 or 50%, right? It's a big number. And so that math clearly works out. And so that's what we do. And so first of all, the billing, it's simple. So I'm at this practice at Dartmouth. Our billing is literally a one-line email once a month. We work with Dartmouth College for their employees. The one-line email, we have 1,850 patients. You agree to pay, it's this much per patient, send us a check. That's it. No EOBs, no coding, no nothing. It is transformative. We think our job, we never ask the question, is there a billing code for this? The question we ask is, will this help the patient? That's the right question to ask. We eventually realized that we were so confident that we would actually lower downstream spend that we started, when we moved into the Medicare space, we started working with Medicare Advantage insurers like Humana and United and et cetera. And we started telling them, why don't you give us the whole healthcare dollar and let us get on with it? So now when we save that money, we get to keep it. And so it's actually transformative. Think about primary care right now is trapped in a vicious downward spiral, right? We pay too little, there's too little resources, we have 7 minutes per visit. So what happens? People end up going to the hospital and the ER too much. What happens is healthcare costs go up. What do the payers do? They're too stupid to do anything else. They just lower our rates. So now instead of 7 minutes, we have 6 minutes. We do a worse job. They go to the hospital more, costs go up. Do we now have 5 minutes to see them, right? When this downward spiral, we all feel it, that we're in this. Well, we said, let's turn it, let's overinvest in primary care, keep people out of the hospital, the ER, save healthcare costs, capture a bunch of it, invest it back into primary care. Now we have more time and more resources. We actually save more money, right? So you turn the wheel the other way. That's what's profound about this, and particularly with these full risk models.
Well, I'll follow up question on that in a minute, but first tell me about the electronic health record component.
Yeah. So the third piece, I often talk about the 4 Ps, Wendy, that you change the process, you change the payment, the platform, right? So the problem is what we really have to build is a new operating system for healthcare and align everything around it. And not surprisingly, the current electronic health records were built to power the current system, right? No duh. Not because they're stupid, but that's the game they're playing. And so they're trying to optimize billing and coding in the 99213s and 99214s, right? Epic is a fancy cash register. That's all it is. All the clinical stuff is an aside. And so we had to do something different. We started by convincing some EHR companies to do separate builds for us. In 2011, at our first practice, we convinced a company called Greenway to let patients see all their notes, to self-schedule, which was radical, 10 years ago. Then we built our own when we raised capital, and we called it Chirp. And Iora is a bird. Iora Health was the name of the first company, and Chirp is how birds. It's a care collaboration platform. Get data from everywhere, create signals, put it into an effector arm. So, for instance, we know when our patients are in the hospital, the ER, and so we and the huddle talk about which of our patients end up in the hospital, the ER. When we prescribe a medicine, we look for a fill from the PBM, and if they don't pick it up, we put a task on their health coach's task list, reach out, figure out why the patient didn't pick it up, right? It's modern software, no need for a manual or training, because we're freed of having to do this stupid CPT billing, it just frees us up to build a very different software. It's agile development, new features almost every day. And so it really helps us. We're building, like I said, it's a new operating system, a tight meld between the technology and the process in order to lead to get to the right outcome.
Well, so this all sounds amazing. What have been the challenges to getting employers to opt into your system then, to turn over healthcare costs to you, or help and to, for their covered employees?
Yeah, so again, we started doing retail. We really got a big boost when we started working with employers, and then really took off when we started doing this in Medicare with Medicare Advantage plans, and now actually directly go to the federal government and have a thing called direct contracting, where we directly contract with them. So lots of challenges, right? So one is really and we keep solving these. So one was really attracting capital, right? These things take money. I made a decision early on that we were taking on a multiple trillion-dollar healthcare system. We needed some real capital to be able to build the systems and the like. So we were one of the first folks to raise venture capital money to do this sort of work. You got to be very careful and raise it from the right people, because there are plenty of the wrong people out there, but we had some great sort of values, people, investors whose values aligned with ours and were long-term thinking. And so one was just raising capital, right? And secondly was, getting the payers to sign up. And we had to start with just the real, what I call wackos, the visionaries. Our first client was Dartmouth College. Jim Kim, some of you may know. He was a Harvard MD, PhD, started Partners in Health with Paul Farmer. He was a MacArthur Genius Award winner, ran the World Bank before he's 50, not a normal guy, right? But he got it. Tony Hsieh, the CEO of Zappos, again, brilliant guy, not a normal guy. Sarah Horowitz from the Freelancers Union, MacArthur Genius Award winner, board of the New York Fed before she was 40, right? So we got some of these really great visionaries to sign up, and then the less visionary people would see the data and they would sign up, right? And then we moved on to some of the really progressive Medicare Advantage plans like Humana, and they signed up for it, and then other people started signing up for it. And as I said, we then moved on to going directly to the federal government, which is really game-changing. And then, getting patients to sign up was not easy in the beginning, right? This is completely different. But now I think they really get it. And then getting doctors to come sign up, right? So we've had to fight each of these things along the way as we've gone. We've gotten opposition from people. We've been accused of stealing people's patients and doctors. I was like, I didn't sneak in the middle of the night, steal your patients or doctors. They voted with their feet. Health plans love us, but they get a little threatened because we have a direct relationship with their patients. We had a health plan shut us out of the network early on because they said, well, patients might think you work for them and not for me. And I said, exactly. It's exactly what we're doing. We've done this for tens of thousands of years. That's what we should. Most recently, we've had, a little bit of opposition from the left wing of the Democratic Party, the Progressive Caucus. They don't like the fact we're VC backed. We and other people like us are VC backed and now a public company. They don't like the fact there's this money in healthcare, but I hate to break it to you, but there's plenty of money in not-for-profit healthcare. I mean, look at your institution like anyone else. There's huge amounts of money. Your CEOs get paid 10 times what I get paid, right? And I think that genie's sort of out of the bottle. So in any case, we face a lot of opposition, but we keep putting our head down, and the goal has always been to transform healthcare. That's what we're trying to do.
Yeah, and so how do you measure that success? And do you have evidence that you're going in the right direction?
It's a great question, Wendy. We track a thing called quintuple aim. I think people may have heard of the triple aim or the quadruple. I add one, the quintuple aim. And we track it every day in every practice. I can pull it up right now. For every doctor, every practice. And we keep tabs on it. So first is patient experience. We're a service business. We track a thing called Net Promoter Score. We do CG caps. So do patients like it? To be honest, they all vote with their feet, right? They never don't like us. They can always walk away. Number two is actually joy in practice, is an experience for the clinicians. Too much of what we do in healthcare, I think, is on the backs of our clinicians. And I think that's not sustainable by definition. We're seeing that in all the burnout, et cetera. So we track that. Clinical outcomes, this is their job, the usual blood pressure control, diabetes control, et cetera, but also, things like self-efficacy. How confident are you in managing your health? Total cost of care is the fourth one, lower hospitalization rate, ER rate, savings rate. By the way, we are consistently lowering healthcare costs by 10 to 20%, not lowering the slope of the curve, actually lowering healthcare costs. One of the things I'm most proud of is I told you we worked with the casino workers in Atlantic City. They were able to give people a 50 cent an hour raise because we were lowering healthcare costs, right? Take money out of healthcare back in people's pockets, particularly low wage folks. And then sustainability. We have to do this in a way that the economics are sustainable, and we've been able to do that. Now, the dirty little secret, though, is it takes a little while, right? In the end, the way we create value is the only way to create value is to make people healthier. That doesn't happen when you snap your fingers, right? And actually, when you start paying attention, we largely have been serving lower income, low wage folks. Is when you take people who have had bad healthcare in the past, you may actually make things worse in the beginning because you do catch-up care. There's underuse as well as overuse. But then what happens is it eventually gets better, right? So you need to make it sustainable over time. And the reason we've had to raise capital is to be able to tide ourselves through that what I call the part of the J curve, where it takes us a little while. So those are the things we track. It's all working. Like I said, as long as you have a little bit of patience.
So the next question I was going to ask you, Dr. Farley, sort of also has on her mind here, a thing we think about all the time, given the hospital settings that we work in, which includes, Emory Healthcare, a VA, and then Grady Health System, our public safety net hospital, is equity. And, in particular, thinking about, Grady, where our patients are un and underinsured, where, whether you like the term or not, social determinants of health / poverty plays a huge role, where we are always thinking about holistic care and trying to tear down barriers. But how does this model work if, is it possible in an un or underinsured population to make this change?
Yeah, no, it's a great question. And healthcare is not like other goods. We actually feel, I feel, and I think we all should feel that this is something that everyone should have. And it shouldn't just be for rich folks. We are not a concierge company. I think, by the way, people who do concierge care is very unimaginative. It's, yes, of course, if you charge rich people a ton, you can do better, but that's not very productive. We don't charge people anything in general. Right. We've tried to figure out how to apply the model to the underserved. One way we've done it is through having very low cost models, subscription models for the underserved. So we did a great practice for a group called Grameen America. So people may know a guy named Muhammad Yunus. He invented the concept of microfinance, where you give the poor tiny little loans, and he's pulled millions of women out of poverty. By the way, if you give We want to pull people out of poverty, give loans to women and not men, because women will actually help their family. Men will go to the bar, and then put them together in groups, and they help support each other. And so they came to the U.S. and they had, tens of thousands of borrowers, largely undocumented women in New York, and we built a practice for them. And they'd said, we can go to the FQHCs, but we wait all day, and they make us feel like it's charity. And so we created $1 a day primary care practice, where we did all this stuff, and they paid $1 a day. And if you couldn't pay it, pay what you can. And that worked fairly well. Now, we do a lot of work in Medicare, which is great, because the good thing about Medicare is everyone over 65 counts. And with MA plans, you can get, we work with 0 premium and 0 copay Medicare plans. So we can work with low income. And by the way, it works better with low income people, because again, we can make a bigger difference because they're sicker. And so where we are in Phoenix, we're not in Scottsdale. We are in Indian School, which is sort of trailer parks and Hispanic areas. I think Medicaid is tougher. We have tried really hard to work with, and by the way, we work with plenty of duals, Medicare, Medicaid. Straight Medicaid is harder, really for 3 reasons. And we've tried really hard to work with it. One is the churn. The problem is many Medicaid programs, if you go on and off Medicaid, because of you get a job, whatever, that's the problem, right? We need stable populations. One of our competitors, a company called Q Lions in Seattle, tried to get a managed Medicaid contract. Then 80% churn of patients, year 1 to year 2, lost their shirt, went out of business, right? Number 2 is, remember I told you this multi-year investment? So people like Boeing, the casino workers, they were willing and able to make an investment this year that paid off in a year or 2. These stupid Medicaid programs, have to zero their budget out each year. And they have no way of actually making investments this year that don't pay off in the same year, right? So that was dumb. And then the politics sometimes of competing against FQHCs, this you're stealing our patients thing. So we are trying hard. We will continue to work hard to try and figure out how to do this in Medicaid. But I think the models work incredible. These health coaches from the community, because of this extra money we're making. So we, in all our Medicare practices, we give people Uber rides to come see us for free. We can do what it takes, right? We can buy them air conditioned. We can do whatever we want, right? And I think it's the models work really well for low income people. There's some structural barriers in Medicaid and some political issues that people need to get over, but in general, I think it can work.
And those political issues are often like pretty big walls to get over, but getting bigger every day. I want to ask you a couple questions about the future of healthcare, and then we've got some questions in the chat. So I want to leave time for others to be able to ask. But I know there's new chapters in your story. So, you established Iora. It was acquired relatively recently during the pandemic by One Medical. And now I know Amazon's making a bid for One Medical. So the trend has been for these non-healthcare companies to get in the game. Pros, cons, should we be concerned about this? Is this, going to allow for more innovation? What are your thoughts?
Yeah, so the answer is a little bit of both, about whether we should be worried or excited. Clearly healthcare has become a business, and I said this applies to nonprofits as well as for-profits, right? And I think the good news, maybe the glass half full view, is it's allowing people like us, new entrants, to shake up the medical industrial complex. To be quite honest, we have built in this country a medical industrial complex. It is the big health systems, the big health plans, the pharma companies, et cetera, who are all sort of in cahoots, to be quite honest, not to make us healthier, but to actually gin up more business, which often means keeping us not healthy. And I think they have zero incentive to change the system. And remember, a practice full, we're making money, what's the problem? And I think having people like us come in who are not trying to fill hospital beds or not trying to, sell health plans and be aligned with the consumer, I think this has real potential. The thing to be worried about is there are huge information asymmetries, power dynamics. So we have to be very careful. This is not just another business. This is about culture and values. I think we're doing it well. We're trying hard. But there are other people out there, particularly as more money flows in, who I think are not necessarily doing that and cutting corners and, playing all sorts of shenanigans, as I'd call it. I think what we need to do if we're going to go down this road is really hold people to long-term thinking. I think the point of this is to serve all stakeholders, not just investor returns, but also the patients, et cetera. I think, by the way, there's a huge role for physician leadership here, right? I think one of the things we bring to the table as physicians is really, thousands of years of being dedicated towards serving our patients, and which is something that some of these folks, entrepreneurial medicine, et cetera, don't have. And I think there's a real role to make sure that these voices keep getting heard. I'm very proud of the fact that we're sort of physician-led, et cetera, but not everyone is. And I think it could be problematic.
Yeah, no, I certainly agree with that. And, so you talked about the physician role in the future, and you mentioned, the importance of physician leadership, and I really underscore that as well. But that's not the only role of doctors, but, now we have more advanced practice providers, we have more tech, we have artificial intelligence and other kinds of technologies. We've talked about the role of community health workers. So what's the future role of doctors? Because I definitely don't want to be the person who's in the room for 7 minutes, like making a medication decision and giving a prescription and then letting all those other people do, other parts of this. What's the future for doctors?
Yeah, no, I think, I think we need to help create that, right? All of us, and not be sort of just passive bystanders. I think we have an investor, Vinod Khosla, used to run Sun Microsystems. He sort of says, we're going to create AI and it's going to replace doctors. I think that's sort of silly. I think there's a huge part of our jobs, which, ought not to be done by us, right? That's fairly rote. And we all know what those things are, and computers ought to do those things, right? And I think we ought to cede some of that, but I think there's the human part of the job of really eliciting what people are doing and what they're feeling, and making plans and helping them execute on the plans that we ought to keep doing and we're really good at, right? And humans are really good at. The role of the doctor, if you think about the doctor in our practices, it's not to just see one patient at a time. I really think it's this being responsible for a population of people, that these people are mine. And they are my responsibility. And I'm going to help them improve their health, keep them out of trouble. And my job is to have this whole array of resources, whether it's health coaches or technology or groups or, data, and use those to try and manage those populations. And the great thing about healthcare is it's completely variable, right? It's many of the stuff can't be protocolizable. The great quote from Anna Karenina: happy families are all alike, unhappy families are unhappy in their own way. Right. And I think this human sort of thing of trying to figure out the right plan, what's going to work with this patient, is still our job. I think it's pretty exciting if we allow it to go in the right direction, but it could be dangerous if we don't. But there's a real role, I think, for docs here.
So you're a primary care doctor, and you've talked a lot about primary care. I'm a specialist, as are many people on this call.
Yep.
So how does this work for specialists, referrals to surgeons, et cetera, like, because you do have to pull in different types of expertise.
No, absolutely. So first of all, we need to start organizing healthcare not from our point of view, these stupid little silos, from the patient's point of view. The patient actually doesn't care if we're a primary care doctor or specialist. They want their problem solved. And what we need to do is sort of make sure that we each play the right role and then coordinate them well to get the right outcome for the patient, right? So what we do is we say, look, there's a good chunk of things right now. So by the way, this model where we split the patient up into little pieces, and their cardiologist manages their hypertension, and their pulmonologist manages their asthma, and the GI doc manages their GERD, and the primary care doctor writes for flu shots, that's stupid, right? It really is sort of, how do we collaborate to do this the right way? I think we sort of think in three ways. So one is primary care ought to be doing more than it could. And, many of what now are specialty referrals are really doctor to doctor questions, right? I got this patient, and we all do this informally a lot with these sort of curbsides. And we've sort of put that in place, and we do a lot more of them because it's better for the patients, better for everyone, right? And, I think it's how do we help do it in situ, and then send on the patients who need to. And then, is really find the people who are going to be practicing, real value-based stuff, right? Not ginning up more procedures, not, doing tests because you can or because it gins up revenue, but really that it's providing value to the patient. I think there's a huge role for specialists. We collaborate with a lot of people, but it's got to be sort of doing it a different way. The big problem is that the models of care I'm talking about, they're not a little different. They're completely different than trying to optimize fee for service versus optimizing these sort of value-based things. I think what's really hard is the old having one foot in the dock and one foot in the canoe, which is the reality for a lot of people. And I think what we've just made the decision that it's time to just jump into the future. And I think with the mistake people are making is they're trying to go slowly into the future. And maybe that's the worst strategy. Maybe you just got to go fast into the future, right? Before the devil even knows you're there. And so that you can actually, because living in both worlds at the same time is really, really hard.
No, that's true. So I'm going to move and get some of the questions out of the chat. So everybody, please feel free to add more questions to the chat, raise your hands, etc. So question, in my prior experience working for a full risk capitation model, I observed heavy emphasis, and this is a little bit what you were talking about, on utilization management, and felt I had to be in fighting mode to get services approved for my patients. Do you feel that's a part and parcel of full risk capitation models?
Yeah, so I think we ask a question every day, how does this not become sort of managed care of the 80s, which is the last time we played with these models, right? And I think it was there, we weren't managing care, we were just managing utilization, and I think there's lots of evidence that these sort of gatekeeper models don't really work, right? Yes, they work for a short time to tamp down costs just by making it harassment, but they don't lead to optimal outcomes. Again, this is why I think one has to have a longer term view on these things rather than a short term view. So in the longer term view, people need to get the care they need to get, right? And I think what we do, and you've got to be very careful. So number one is we never put our doctors in a position where they have to trade off, their salary and doing these things. The doctors are salaried, period, right? You don't want people to have to make personal decisions about, if I order this test, I won't get to send my kid to college, right? So we don't do that. Number two is we try to do things collaboratively, right? So if there are sort of big ticket items, we get together as a group and talk about it. Like, what do we think? And this two heads are better than one, not because we're going to deny it, because we're trying to come up with the right answer. Is this the right thing to do for the patient, or is there another path to do it, right? And too often, I think, again, there are shadow sides to everything. I think if fee-for-service would have too easily do things, you want to make sure that you don't make it too hard in this system to do it. So again, it's all about, by the way, the fourth P, I talked about the process and the platform and the payment. Maybe the most important one we didn't talk about, Wendy, which is about building, is people and culture. And that's, I think, what we've really spent a lot of time doing, is how do we create sort of a culture and a collaborative group that we can actually, be stewards of these resources, because they are, these are finite resources. And we want to spend them well and smartly on behalf of our patients, and of society. But we do that collectively. These are hard decisions. But I think if we just frame it the right way, we might have a shot at it.
And just different, how big are your practices? When you talk about bringing people together, how big of a practice are you talking about?
Yeah, so our practices are small. They're sort of four doctors, 7,000-8,000, a few thousand patients, and then we have 10 or 12 practices in a market. So as you know, we have on the Iora side, which is sort of the senior side, we've got 7 practices in Atlanta, if I'm counting right. And then we have one medical practices, another 5 or 6. But those are the scope. We try to push these decisions as locally as we can. I think the trend in healthcare has been to centralize them, and I think that's not necessarily the right thing. You want to keep these decisions as local as you can, so you can actually be attuned to sort of cultural differences, et cetera.
All right, another question. Do you feel that, so Georgia, unlike Massachusetts, where you are based, is not a Medicaid expansion state? Do you feel that Medicaid expansion will allow for the opportunity to utilize these care models better with that population?
Yeah, so Medicaid expansion is necessary but not sufficient to do this, right? So obviously, if people are uninsured and have no coverage, these sort of models, it's very hard, except for these sort of dollar a day or charity models. I think if you have Medicaid Advantage, now we have a shot. There's still these big problems in Medicaid, right? These work hour restrictions where people are cycling off month by month if they forget to sort of file something. I think it's so stupid, right? These people are still going to be a problem. And what we need is actually, again, long-term thinking and stable financing to be able to make this, right? The only way to add value is to make people healthier. The only way to make people healthier is make long-term investments in these relationships and in their health. And, you know, when you keep cycling people through, this is just so short-sighted. So again, I think, yes, Medicaid expansion is great. And of course we should do it, but we also need to have stable Medicaid funding for these patients.
So again, sort of continuing a little bit of a theme. So how do you manage patient selection? In other words, you could get all the complex, difficult to manage patients in your system, or you might only get healthy working people from a participating company. How do you manage that?
Yeah, so again, I keep going back to this like a broken record. It's about long-term alignment. When we first started, so the key is you have to risk adjust what you're getting paid, right? If you're getting sicker, older, complex patients, you should be paying more. If you get healthier, younger patients, you should be paying less. And so when I first started, we had no idea what the numbers were. So we actually said, we're going to be pretty transparent about our economics here and how much we're seeing people. And if I'm going to pick a number, you know, X amount per person per month. And if it turns out that we need more, we're going to ask for more. If it means if we need less, we're going to give it back to you. And we did that. So with the casino workers in Las Vegas, we ended up getting much more sicker and complex patients than we thought. So we actually ended up asking for and getting a higher rate, you know, after 6 months. The freelancers in New York, they end up being really healthy. We were getting paid way too much. And so we actually lowered our rate. Right? You're like, why would you do that? Like, well, because this is about a long-term relationship. We signed, by the way, like when we signed our agreements with Humana, 10-year contracts, not 1-year contracts, not 3-year contracts, not even 5-year contracts, but 10-year contracts. Because I think that's what we need to get in the habit of doing, is saying we're going to align ourselves over a long period of time. We're going to adjust as we go and be in a long-term relationship, as opposed to this sort of adversarial who can screw who over in the short run model. So that's that. You've got to risk adjust. If you can risk adjust it right, there are a variety of ways to do it. And, you know, we can have a long conversation about Medicare's risk adjustment model, which is this HCC model, which, you know, it's good, not great. And it's under a little bit of fire, as it should be, by the way. And but anyway, you've got to risk adjust so you actually are able to take care of sicker people.
So the other part of healthcare costs that's spiraling out of control is pharmaceutical costs. And so how do you manage that, and how do you get your patients access to pharmaceuticals?
Yeah, no, that's a great question. So remember, cost of care, this is economics 101, is price times quantity. What we've been working on is the quantity side, is, you know, let's get people the right number of time being in the hospital, et cetera. We have almost no way of controlling price, right? Because price is all about being big, and pharmaceutical pricing is ridiculous, right? We've allowed, I mean, I think it's ridiculous, by the way, that that Medicare cannot negotiate, until very recently, could not negotiate the price of the drugs. Like, who thinks that's a good idea? Right? Whatever price you want, we'll pay. Like, that's ridiculous, right? And so so this is beyond us, right? So by the way, one thing I'm excited about, we talked about sort of Amazon, you know, is in the process of buying One Medical. There are all sorts of things which one needs to watch out for, but the thing that's exciting is, guess what Amazon's really good at, is rationalizing pricing. And some of the pricing stuff in healthcare, it's just ridiculous right now. It's obscene. And by the way, health systems like Emory are prime culprits, as is Mass General, in sort of some of this ridiculous pricing stuff. But guess what? People like Amazon are really good at sort of trying to cut through all of that stuff. So again, we have very little ability to actually fix that and deal with pricing. You know, occasionally you can find substitutes and the like, but I think as we get to some scale and some of these big guys like Amazon or Walmart come in, that will likely lead to some rationalization.
All right. From the residence room, how do you use patient-reported outcomes to guide clinical actions to further improve patient outcomes?
Yeah, great question. So this is a work in progress, right? And I think, you know, the way to make this stuff work is to continually iterate on it, and you need to be guided by something. And actually, patient-reported outcomes are really good. So many of the outcome measures we have now, things like the HEDIS measures, are sort of like the drunk with the keys under the lamppost, right? We're looking because the light's brighter, but it's not really what matters, right? And I think some of these patient-reported outcomes, like, how do you think your health is? How confident are you in managing your health? How's your pain and function are actually probably much better measures that we can use and what we can use to rapidly improve what we do, trying an intervention, see if it works. If it does, great. If not, try something else. And so it means, by the way, I think one of the mistakes we make in healthcare when we measure these things, we do it rarely. So most people, when they check on patient experience, they do it once a year with the CG CAPS thing. Once a year doesn't help, right? It's just sort of what we do is every day in every practice, we track Net Promoter Score. And so what you can do is literally every day, if you see someone starting to dip down, you can then make a quick adjustment, right? So it's actually maybe much lighter weight, but quicker. So you can make quicker loops. And that's what we have to do.
So there are a number of questions about the fact that we are stuck. Most of us are stuck in a fee-for-service model. We've been talking about value-based care forever, but most of us have not really seen that. How can physicians be more disruptive? How can we be disruptive to get us to a different future? And how do we get training so that we can, understand the best ways to work in the system?
Yes, I love Dr. Del Rio, that we are so addicted to fee-for-service model, it's hard to change. I think that's exactly right. And by the way, the FQHCs are prime culprits in this, right? Well-intentioned, but completely addicted to the T to fee-for-service. And I think it's just the wrong way to pay. It is the wrong way to pay for primary care, right? It's episodic, it's transactional. We will not make progress until we sort of move beyond it. When one does these things, one needs to have a theory of change. And my theory of change has not been, there are people who say, well, we need to go fight the ruck and we need to do all this policy change. And the problem is this medical industrial complex has sort of captured the policymaking apparatus. And I think that's not going to work. So our theory of change, by the way, if you notice what it is, it's what I call the Southwest Airlines theory of change. We're just going to build a different mousetrap and let customers vote with their feet. Right. And that will sort of kick the rest of the industry in the behind. Southwest Airlines, high fares, crappy service. What changed? It wasn't American and United deciding to get better. It was, customers voting with their feet, and that made them change. Right. So that's what we're trying to do. I think there's stuff we're doing that I think anyone can do, which including huddles and health coaches and integrated behavioral health. And many people are doing a little of it, but it's very hard if you're not actually working in a different payment model. I actually think that's the key. Medicare, what's interesting is Medicare is leading the way here. Would have thought that the government would lead the way here. Medicare has said over and over again is by 2030, not that long from now, we want 100% of all Medicare beneficiaries in full risk up and downside models, 100%. They keep saying it. There's a pretty good bipartisan agreement on that. We and other people are moving rapidly in that direction through, various models like the GPDC and now called ACO REACH and et cetera. So I think it's going to happen, right? And eventually people are going to start moving that direction. Is there training for this? I think it's ridiculous. Again, I'm still on faculty at Mass General, that we're training people in primary care models that are pretty old school, to be quite honest, and stuck in fee-for-service. And, my dream is that we end up being able to open practices like this in conjunction with folks like Emory and Mass General and be able to have residents rotate through and have at least a look and see what it might look like in a different model. And I think it would encourage a lot more people to go to primary care, by the way. And so, by the way, we now partner as part of One Medical. We are partners with Emory, actually, and we are co-branding practices with Emory. And so I think at some point we have not sort of moved that into the teaching realm, but I would love to be able to do that over time.
I think that actually addressed this question. I don't know if you have anything further to add about the shrinking pipeline of future PCPs.
Yeah,
and long-term strategies to increase the number of trainees going into primary care. It's
huge, right? So I think our limit, very selfishly, our limit to growth at the moment is not capital, it's not patients, it's not obviously building, it's not technology, it's PCPs. right? That is our constraint to growth, period. In every other country in the world, twice as many people are primary care docs as specialists. We have that flip here for all sorts of reasons. I think obviously there's a money reason, in general, specialists who, not ID doctors, sorry, Wendy, but many specialists get paid twice as much as primary care doctors. I think we could fix that. But also because the job sucks, to be honest, in a typical primary care practice with sort of the typical infrastructure and typical payment model. So we can fix that. And I think if we can expose people to it, this is actually a great job. I think if I was thinking of where is the opportunity to make a difference in healthcare right now, it's in going to fields that are cognitive and primary care and building these models out. And by the way, we need lots of specialists working within these models too, right? Again, stop with this sort of madness of the silos, but how do we create models that comprehensively allow patients to improve their health, right? And there's a role for specialists in primary care in there.
Yeah, absolutely, 100%. So last question, which I think is a little apropos to where we are at this moment in this discussion. Burnout. What's been the experience of your providers in your system with burnout, and compared to the epidemic of burnout that we are seeing?
So it's better. It's a short answer. And we've done the Matlack burnout inventory and a couple of other surveys and compared it to some benchmarks, and we're better. But it's still a hard job, right? I think being a primary care doctor is hard, I think, for all sorts of reasons. We have much smaller panel sizes. On the Medicare side, our docs have 600-person panel sizes, not 2,000. They've got 2 health coaches. They've got a behavioral health specialist. We've got much easier technology. We're not checking the boxes. So we solve a lot of that. It's still a hard job. In some ways, it's almost a harder job, actually, Wendy, because instead of just trying to bill as high as you can, we have trying to help people actually improve their health and stay out of trouble. That's a lot harder than just, in a typical practice, I get paid for telling you what to do. I actually don't give a whit whether you do it or not. In our practice, we have to make you do it or help you do it. That's a lot harder. And I think this is something we all need to work on, right? Because these jobs are not sustainable. And by definition, by the way, this whole idea of we should teach people meditation and coping mechanisms is ridiculous. Like, no, we have to fix the freaking job and make it a doable job and with doable economics. And that will create sort of the future we want.
I guess on that note, and we do care if they do it or not, I will say that. But on that note, I will close. I want to thank you so much for spending an hour of your day and joining us to really talk about a new healthcare vision for the future.
Well, thank you. And good to see all of you. All right. Bye.
Bye, everybody.